They are going to be on Facebook Live.
No, I don't think.
See. Like this guy. I have to market my grandfather.
That one. No.
Oh, yeah. I said I have to.
Nataraja Pillai Oration. Dr. Gaurav Shah is no new face to our society, being a regular visitor and contributor to the VRSI. He comes from San Francisco. He's a graduate from the University of Illinois at Urbana-Champaign. Medical School, University of Illinois College of Medicine, internship at Kaiser Permanente Medical Center in Santa Clara. And his residency was at the University of Minnesota, Department of Ophthalmology, did his fellowship at VRSI Hospital, and he's currently the chief of Retina at the California Pacific Medical Center in San Francisco. And he's also part of the West Coast Retina Group in California. There are numerous awards for Dr. Shah. We all know his caliber, the way he is. He's a very good teacher, so he's been receiving a lot of awards. This is just to name a few: Lifetime Achievement Award from the American Academy, Charter Inductee of Retina Hall of Fame, OSN's Top 150 Retina Specialist in 2016, American Academy of Ophthalmology Senior Achievement Award, American Society of Retina Specialists Senior Honor Award, and Academy of the Lifetime Achievement Award. He has over 200 publications to his credit, 17 book chapters. He is currently the executive board member of ASRS and will be the president-elect of ASRS for 2026. Dr. Shah resides with his family in California and San Francisco. He is very passionate about his work, especially in surgical retina. Takes keen interest in teaching his fellows. He also gives time to Pacific Eye Foundation for some outreach work. And more importantly, he has a very keen passion for traveling and does a lot of traveling with his family. And VRSI is really proud to confer this Sundaram Pillai Oration Award to Dr. Gaurav Shah. I invite Dr. Gaurav Shah here.
Sundaram is actually my father. And Natarajan is my grandfather's name. They didn't put Preeti Shah there.
First of all, thank you so much. Awards are opportunities, and I want to kind of thank, because I think for me, awards are friends and the trophies are our family, so thank you so much. I want to thank Dr. Natarajan for his contribution and his sort of dedication for education in society and all the leadership. So I'm going to give you a talk on lessons learned from OMIC. I also want to recognize our team of people who worked on this. The first two are two residents at CPMC out of our 12 who are going into retina. Second, Dr. Chin, who's listed on the right as well. He's one of our fellows who's joining West Coast Retina. And Flora Lim, she's at the American Academy of Ophthalmology, and I've had a chance to work with Flora for numerous years. So I want to talk a little bit about the IRIS registry. The IRIS registry was launched in 2014. It's the largest registry in the world. There are 669 million visits, 70 million unique patients, 15,000 clinicians, and about almost 2,900 practices. So this is where big data is really big data. This is the only one of its in the world. What's the data that's available? It's demographics, history, exam, diagnosis, procedures, and medications. There's always pros and cons to big data, so this really gives us unique identifiers across participating practices. 82% of ophthalmologists participate in the IRIS registry data. It's highly generalizable, and it has a very, very large sample size, as you'll see. There's large-scale treatment patterns and surgical rates that have been published. It really compares real-world data to clinical data, and I think this is what we really base our decisions on. Of course, there's cons to everything. It's retrospective. There's inherent coding errors. There's no data on death cannot distinguish from last time to follow-up. There's lack of anatomical data, minimal academic center contribution, but that is changing. There's lack of genetic testing information, selection criteria, real world versus clinical trial patients. So some of this stuff, we can't obtain. The data is the data. But as usual, retina leads the way. If you look at the number of publications we've done from the IRIS registry, there's 51 retina publications, all published in either ophthalmology retina or ophthalmology or AJO or archives, 24 glaucoma, 20 cataract, pediatrics, strabismus, oncology, plastics, and cornea. 51 total retina studies. This is an encyclopedic summary for the clinicians. We're in the process of writing a summary paper of all 51 papers in retina, so it's a one reference for clinicians. These are the topics, medical, surgical, that is going to deal, and I'm going to show this to you. This was one of the papers on pneumatic retinopexy as we talked about. This was from Nick Yanutzi and all. This was looking at analysis of iris registers for myopic choroidal neovascular myopic CNVM in the U.S. This paper single-handedly got therapy approved for myopic degeneration for anti-VEGF therapy in the U.S. So this is critical when it comes to insurance reimbursements. This was another nice paper from Rishi Singh, one of our colleagues, on DME in different races in the U.S. I'll also talk about this paper, was our paper looking at PVD and when do second tears occur, because this paper also helped us to get patient visits to be reimbursed by insurance carriers. Wet AMD, you can look at all these topics, drug therapies, cost effectiveness, progression of GA, there's some new papers in that, diabetic retinopathy, socioeconomic disparities, because the number of patients you can get from the IRIS registry is very large. Endophthalmitis rates, ancillary testing, and so on and so forth. So lots of things both for medical and surgical retina. I'll briefly talk about three papers. This was a paper that was presented. We briefly spoke about this yesterday about pneumatic retinopexy. And obviously we wanted to update the data for 2019 and look at single operation success rate in the general community and what is the impact of phakia versus pseudophakia in terms of success rate. We identified 13,000 unique patients for pneumatic retinopexy. You can see the demographics. Average age was 64. We also broke it down what part of the country pneumatic retinopexy was done. Midwest, South, Northeast, unknown region. We also looked at their insurance, what insurances they had, and what their nationalities were as well. So all of this data we can obtain. And this was a take-home message. So this paper was accepted, will be published very soon. But this is an important paper because the single operation success rate was 59%. Phakic patients was 65%, and pseudophakics was 46%. One of the other things is the post-operative, there's some complications of vitreous hemorrhage in 9.1%, epiretinal membrane, PVR, and endophthalmitis. But the key take-home message is 59% one operation success rate. And this kind of shows you in terms of what is the operation success rate of pseudophakia versus phakia. Another interesting trend we looked at is, are we getting better at doing pneumatic retinopexy? And the answer is no. 2014 to 2022, we put the same bubble in the eye, did the same pneumatic, and our results were exactly the same. So it has taught us that from 14 to 22, we made no difference in how we did procedure in terms of success rate. This looked at all of these factors as well, vitreous hemorrhage, PVR, no changes in terms from 2014 to 2022. Same thing with endophthalmitis, again, small numbers. So what this paper concluded was pneumatic retinopexy is a good option for the right patient. Single operation success in the community does not equal clinical trials that we've talked about, and we really need to temper patient and physician expectations. If you want to do that, it might require thorough and extensive laser retinopexy. Phakic versus pseudophakic status, for the first time we showed in 13,000 patients that there was a difference in the outcomes of single operation success rate. The next paper, this was also presented at the ASRS, and this also will be coming out in press, was the IRIS Registry outcomes of vitrectomy for floaters. This is a common condition now that people are doing vitrectomy for floaters. And you can argue whether this is needed or not needed, but we wanted to have some data for this. These were all the papers that looked at vitrectomy for floaters, again, smaller case series. But our study was to look at the incidence of vitrectomy for floaters by the year, look at the outcomes, and then more importantly, look at the complication rate. This is a good procedure that can be useful but has real complications and real risks like every procedure. So we looked at the inclusion criteria. The inclusion criteria, they're typically standard. We looked at 28,000 eyes that underwent vitrectomy for floaters. So when you get numbers this big, you can actually make conclusions on something. We have 47% pseudophakic eyes, 52% phakic eyes. If we look at the vitrectomy for floaters from 2014 to 2022, you can see there's a dip in the COVID era, but the number of vitrectomy for floaters has continued to go up. What is very interesting is what hasn't changed is look at the complication rate of 3.6%, which has been noted, but we found a 1.6% rate of endophthalmitis. So this is a procedure that has some issues that we need to be aware of. I'm not saying don't do the procedure, but these are some issues you need to let patients know.
You do?
So 1.6 is much higher. Explanations may be less likely to have suture wounds or tamponades. Are there people who maybe didn't do as many vitrectomies, did these cases? Again, we don't really know that. I think it shows the importance of proper construction, wound construction, and closure of sclerotomy sites. So I think we want to really trivialize the surgery. I really don't like the word floaterectomy. I don't do puckerectomies. I do vitrectomy for macular pucker. So it should be vitrectomy for floaters. And I think patients really should be counseled to these risks. The last paper I'll talk about was looking at PVDs. We were having a problem in the U.S. Insurance carriers were denying us having follow-up examinations for a PVD because they wanted to have a phone consultation after having a PVD. And this really made no sense to us because we all know that retinal breaks can occur after PVD 4 weeks later, 6 weeks later, 3 months later, and so on and so forth. So you would think something as basic as this, insurance companies do denials for us. So we looked at eyes who at least has 6 months of follow-up with 1 year follow-up in the registry, 6 months of look-back, timing of delayed retinal breaks or detachment after initial PVD. And this was important to look at in terms of what are the risk factors. Can we stratify patients into high risk versus low risk in terms of when we see patients? So we looked at 12,803 eyes that were documented with PVD between July 2013 and 18. We looked at, out of that, almost 500,000 eyes who met the inclusion-exclusion criteria. You can only get this data from the IRIS registry. There's no other registry that's going to give you this sort of information. 10,518, so 2.4%, present with a delayed retinal break or detachment. The median time to retinal break after initial PVD was 42. Retinal detachment was 51 days. What is the take-home message? This is the high-risk population that you need to be aware of. Vitreous hemorrhage, by far, is the number one thing. So if somebody has a PVD and a vitreous hemorrhage, that patient needs more monitoring than somebody who does not have a vitreous hemorrhage. But this is the first time it's sort of been shown in a large database. History of retinal breaks or detachment of fellow eye, lattice degeneration, and myopia. So we looked at high-risk and low-risk eyes. This is some poor stratification for us in almost 500,000 eyes, I want to kind of emphasize. And this just sort of shows you 34 days and 51 days in terms of delayed retinal breaks and retinal detachments. We also can look at whether it's a retina specialist versus a non-retina specialist. So median time to delay retinal break and detachment was 42 and 49 days. Non-retina specialist was 37 and 56 days. So follow-up examination after initial PVD is really important. is eyes with no initial pathology. It is reasonable to do once within a 6-week period. But if somebody has a vitreous hemorrhage, the insurance company cannot deny you or cannot deny the patient a more vigilant follow-up. Our data clearly shows these patients will have a retinal tear and can have a retinal detachment. So what are the learning points we can take away from this? There's advantages and disadvantages to using big data registries, but they will guide our practices. Future studies, we're looking at 5,000 eyes who have retained lens fragments, and we've just started looking at post-injection endophthalmitis. We have 29 million injections we'll be looking at who develop what is the rate of endophthalmitis, how did they do, and what were they treated with. So this is going to be very important for something that we do. So again, data is the new currency. Data has no emotion. Data is the data, and we have to interpret that. So I showed you the first team. This is the second team who kind of helps along with this. Both my daughters, my wife who's here. So obviously we always appreciate their support because the awards really are for them. And I also want to invite you to the ASRS meeting in Long Beach in July 3rd to August 2nd. It's going to be a fantastic meeting. And for those planning ahead, the year after that will be in Montreal, and then we're going to be in San Francisco in 2027 at the Moscone. So I invite you all to come to Long Beach and experience Southern California. So thank you again for the opportunity.
So thank you, Dr. Gaurav, for a very interesting big data presentation, and I would request Dr. Kim to kindly felicitate the Nataraja Pillai Oration awardee, Dr. Gaurav Shah. Heartiest congratulations, sir. So moving on to the next cohorted speech, I would request Dr. Vaishali Gupta Madam
So we'll take this
introduce
video.
the award
It's a
for
Facebook Live.
SS Harry Oration awardee.
So how do you feel?
The same. I want to go to Disneyland. Oh, signature.